Welcome to the Rehab and Performance Lab, the Medbridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, founder of Coaches Club, and author at philplisky.com, and a high performance systems consultant in professional sports. Being an athletic trainer, physical therapist, and strength coach, we like to come at this from different angles. We want to explore the latest evidence, but most importantly, we want this to be useful, practical information that you can implement immediately. I'm so excited about our topic today. We're going to talk about lateral elbow pain and maybe how it's more than just doing some eccentrics. Joined by our guest, Dr. Porretto-Loehrke. She's an expert in upper extremity evaluation and treatment, and she does it from a systematic manual therapy approach. Welcome to the podcast, Ann.
Thank you so much, Phil. I'm so happy to be here and very honored to be a guest on your show.
Oh, we're so glad you can join us. I'm looking forward to this discussion. This is a favorite topic area of mine because I always have felt that it's a little bit more than just a very simple, straightforward topic of elbow pain. There's a lot going on, so we're going
Not
to really
just the
dive
tendon.
into it. Yeah, it's just a tendon. It's just one thing. So,
The
uh,
tendon.
so for those people who don't know you, can you give us a little background about yourself?
Sure, I'd be happy to. So I am a physical therapist. I've been practicing a little over 30 years, and I'm also a certified hand therapist. And I got started in upper extremity rehab when I was actually in undergrad. Well, then it was just a bachelor's way long ago. And we had a physical therapist who was also a certified hand therapist come in and give some hand therapy lectures. And I was hooked. I'm like, oh my gosh, this is totally what I want to do. So I spent some time after graduation in different care environments. So I did spinal cord rehab, neuro rehab, and acute care, and all the different areas. And then really settled on when this job opened up at a hand therapy clinic. I was like, oh my gosh, this is the best. And I've been at a hand and upper extremity center for the last 24 years, and seen my fair share of lateral elbow pain. And I think whether it's called tennis elbow, lateral epicondylitis, lateral epicondylosis, these are patients that not everybody is like striving. They want them all on their schedule, right? I mean, someone's like, oh no, I got another lateral elbow pain. But they're really actually fun to treat because it's not, as we find out, we look at the literature and in practice, it's not just the tendon. And I think understanding that deeper level of things going on can really make a big difference. So there are numerous causes of lateral elbow pain, but it's not always just the tendon.
It isn't, and that's the thing, and we'll get into this more. But I always think about, just even in the innervation of the where the innervation's coming from, and coming from the neck, and all these different types of things. It can be so complex, but hopefully we're here to simplify it today. So, what do you think? Why is this important? What questions should we be asking ourselves as clinicians so that we can say, hey, how can we do a better job at this? Or maybe it's to confirm we're doing everything we should be right now.
Well, I think the first part I think is just understanding the anatomy of the elbow, and I want to talk a little bit about just the joint structure because that will help us then when we start talking about other things like microinstability and chondropathy, because we see in the literature that it's not just the tendon, and in some studies, which we'll discuss in a little bit, that it actually the underlying problem was the microinstability of the lateral ulnar collateral ligament. So I'm going to back up a little bit and just kind of talk about the elbow itself from an anatomical standpoint. Now, I'm going to be focusing on today's episode. We're just going to discuss more for adult related issues. So, those that are skeletally mature. There are a lot of different reasons for lateral elbow pain in the younger population. And that's speaking here to the choir, right? Like the
Right.
Banner's disease, osteochondritis dissecans. So, I'm going to reserve for another time with Phil, but we're going to talk about now some of the things that happen to the mature skeleton. So, if we think about the anatomy of the elbow itself, it's not just a hinge joint. So, we do have the humeral ulnar joint where that trochlea articulates to the proximal aspect of the ulna. But We also have the humeral radial joint where that radial head articulates with the capitulum. So that and the proximal radial ulnar joint where we have the radial head articulating with the proximal aspect of the ulna, that's going to be responsible for 50% of our forearm rotation. And we also then have the humeral radial and humeral ulnar. All three of those joints share a common joint capsule. So when there's an issue, sometimes we see this too with big traumas. When there's an issue with elbow flexion and extension, that can also affect our forearm rotation. So, when we think about then the ligamentous support of the elbow, so focusing on the lateral elbow first, so we think about the lateral ligament complex, which is the lateral ulnar collateral ligament, then that's going to be our strongest primary stabilizer for the lateral elbow. So, it comes from the distal aspect of the humerus and attaches to the ulna. Very strong, very stable. When we have injuries to the lateral ulnar collateral ligament, that can lead to something called PLRI or posterior lateral rotatory instability, where basically you see the lateral aspect of that hinge joint start to come apart because of that ligamentous laxity. And it's usually due to trauma. And we're going to touch on, we're finding some micro instabilities there that we are seeing when patients are anesthetized and then they're tested.
Okay, so as we think about that anatomy, when we're talking about someone coming in with lateral elbow pain, how do we, kind of evaluate those structures? What is the tissue involved? What are the muscles involved? What does that look like?
So, when you think about from a tendinous standpoint, we've got the extensor carpi radialis brevis or ECRB, and that's our strongest wrist extensor. And if you look at the structure of that, it's a larger muscle belly, more in the center of the back of our dorsal forearm, but it has a very long tendinous attachment where it comes off of the lateral epicondyle. The lateral epicondyle is only this small half a centimeter by half a centimeter box. So you think about that strong muscle tugging on that very small proximal attachment. So that's the primary muscle. A secondary that we see sometimes involved is the EDC or the extensor digitorum communis. Sometimes we can see them together, and other times we just see ECRB alone. So then when we think about from a joint standpoint, so underneath that we have the radial head. And the radial head, that can be a pain generator in and of itself if we've got hyper or hypomobility. And it can also, that annular ring, if that's stretched out, that can result in more of a shifting of that radial head, which could cause some impingement. And in some cases, that can impinge on where that radial head attaches articulates on the convex side of the ulna, and that will also cause impingement. So when we look at as far as patients that have issues with tendons, it might not all be the tendon. It may be more articular things involved. And there was a study by Sasaki in 2012. I love this study because it helps us to appreciate it's not just the tendon. So what they did was they did arthroscopies of 31 patients, 31 elbows undergoing surgery for lateral epicondylosis. What they found was cartilage injuries in the capitulum were found in 65% of those cases, and cartilage injuries in the radial head, a whopping 81% of cases. So they found the absence of ECRB tears was independently associated with a higher risk of cartilage injuries of the capitulum. So I think it's important for us to appreciate that alignment and loading makes a huge difference. I mean, even when you think about too with the humeral ulnar joint versus humeral radial, humeral ulnar joint is its form. The form provides stability. What about the humeral radial joint? It's force, it's muscles helping that radial head articulate with the capitulum. So you think about if you just have things off a little bit in alignment, how that could then start the whole process of cartilage degeneration.
So let's kind of let's take a step back here and say we know, I think I should let's get everybody on the same page. If we a lateral epicondylgia, lateral epicondylosis, that talk to me about the research that says that is tendon degeneration involved. So there's a good body of research that says that actually there is a tendon degeneration. Tell us about that and what the traditional treatment is for that.
So when we think about being a tendon only, so that's where we go back and we see this involved in the highest is from ages 40 to 49 that we see a true tendon problem. So we see decreased loadability, and we see also an interesting thing where we see an increase in pain and influx. So there was a systematic review that looked at why do these tendons hurt so much,
Right.
that they actually found in 13 of 20 studies of somatic pain for lateral epicondylgia or OSIS that CGRP and substance P. So CGRP is calcitonin gene-related peptide, and we hear a lot about CRPG when we talk about dry needling as well, how the dry needling helps to flush that out. But they found in those patients that CGRP acts as a pro-inflammatory for the peripheral nervous system. So that leads to even more of that central sensitization. I know that Fernandez de las Piñas also has looked at when you have a longstanding tendon problem, it causes central sensitization, meaning your whole body's more sensitized to pain. You have decreased pressure pain thresholds, and it's all because it's been hurting for so long. So the tendon issues, when we think about treating a tendon issue, that's where we go back. A straight tendon issue, if you're doing your eval. So I want to talk about the Cozen test first. So the Cozen test, what are we looking at there? So the Cozen test is just resisted wrist extension with the elbow inflection. So the elbow's flexed, you give resisted wrist extension. Well, what happens? Well, when you resist them, they have pain at the lateral epicondyle. So the problem is, as a clinician, that doesn't tell us if it's a tendon problem or a joint problem. So what we want to do is we want to divide this up, because again, if everything I do hurts, it's really difficult for me to define like what's the problem. Because if they have an underlying joint issue, it's going to hurt with resisted wrist extension as well as a tendon. So if we break up, if we have a quadrant now, we think about, let's separate out, let's try to test the ECRB, and you also test the ECRL with that. So let's do resisted wrist extension with radial deviation, and then let's compare that to resisted wrist extension with ulnar deviation. Ulnar deviation, we're getting more ECU. How often do we see ECU involved in lateral pain, lateral elbow pain? We don't, right? So the elbow's in an extended position, the wrist is in neutral, and we're going to give our resistance with resisted wrist extension with radial. And the patient says, ow, my next question is where? And they point to their lateral
I
elbow.
think that's actually the most missed question by every diagnostic test throughout the body is, does that hurt? The next has to be where. It,
Where?
it has to be where. And in this case, that's true. That's even more so true.
Right, exactly. So then I follow up immediately with testing resisted wrist extension with ulnar. So if the ulnar deviation is less painful or not painful at all compared to the resisted wrist extension with radial, that leads me down to the trail of a tendon issue, because I'm loading the joint when I do resisted wrist extension with ulnar. So if it's a true tendon issue, we're going to have our most painful provocation with resisted wrist extension with radial deviation.
That's huge. I want everybody to kind of just sit back right there, and get that information there. So we're not just identifying, is the elbow painful to palpation? Is the elbow painful with wrist extension? We're dialing in and saying, okay, what specific muscle is actually painful? And you're saying that if I have the radialis being painful and not, because I think it's got to be both, right? It's got to be, because if both are painful, I think we'll go down a different road. But if radialis is painful but ulnaris is not, then I'm truly dealing with what we would consider traditional lateral epicondylgia, lateral
A
epicondylosis,
true tendon
however,
issue.
a
Yes,
tendon issue. Is that fair?
correct. Yes.
Okay, so from there, now before we go and evaluate even more, I want to hear. I would like to hear if what the thoughts on then if it is indeed just a tendon, because I think we're going to spend more time on the things that maybe aren't that. But if it is a
Yes.
tendon, what should we be doing for that? What should that look like? So we've ruled out any other ligamentous, cartilaginous,
Mhm.
instability. All that is, and we're just in a tendinopathy. What do we do for that?
So that's a great question. So a true tendinopathy. And this is where Ann Lucado and Associates came out with the clinical practice guidelines for treating lateral elbow pain in the Journal of Orthopedic and Sports PT. It was published in 2022. And what their recommendation that clinicians may use soft tissue mobilization, including manual release therapy. They also that you could use instrument assisted soft tissue mobilization, but they found conflicting evidence as far as with the use of what we traditionally would think about with transverse friction or cross friction massage. Now, there are several studies that do show the value of transverse friction. There was one study that was published in 2018. It was a randomized controlled trial. They had three groups of people. One had a splinting and stretching, one had a steroid injection. Group 3, now I wish they would have not done the lidocaine injection with it. They did lidocaine and deep friction massage, but they found at the 6-month follow-up that only those patients with the deep friction massage had significant improvements.
Mm.
So I wish they would have taken out the
Yeah, because if they, if they did the lidocaine, did they somehow interrupt that central sensitization
Yes,
cycle,
yeah.
or, right? Because
Exactly. So it's like
it could,
too many
yeah,
factors. And
yeah.
that's what I see a lot of complicated patients. And I'm always like, okay, I don't want to introduce too many things at once because I want to know what's helping and what's not. So anyway, so as far as treating the tendon, we do know that that soft tissue mobilization can help. Dry needling, we're seeing more and more in the literature, and actually, dry needling is finding more useful than using a corticosteroid injection.
Oh, wow.
So there was a meta-analysis done in 2020 that looked at 7 studies. 320 patients. They found improvement in pain related disability, pressure pain sensitivity, and strength in the short term for those patients. And when you compare the two, and this was published in 2021 by UGAR, dry needling versus corticosteroid injections. And now the little caveat with dry needling, there's a lot of different ways to do dry needling. You know, I know the way I had been trained, and then I talked to other people. I'm like, oh, that's very different. So there's a lot of different ways. And the way they did it in the study, they had 15-minute sessions, 15 needles. And what they did was they put the needle in along the ECRB tendon down to the bone, and they rotated it 3 to 4
Mhm.
times, holding that in place. And what they found was in 6 months, both groups, the corticosteroid injection and the dry needling improved, but the dry needling one, that group had greater improvement in that patient rated tennis elbow eval. So um, they recommended dry needling over corticosteroid injection. And I think too, you think about patients too that are diabetic, that their blood sugars are going to get messed up with the corticosteroid injection. We see that it's really not disease modifying. It's better if we can address number one, the loadability of the tissue, right? So we want to calm it down, but we want to start to load it now when we're able to. So this is where our discussion on therapeutic exercise. We know that loading's beneficial, but the key one caveat is we want to make sure that humeral radial joints in good alignment, because if they have a joint issue, which we'll get into in a little bit, if you just start loading it without addressing the joint alignment, it could potentially worsen their symptoms. So there was a nice study that was done. We think about eccentric loading. Okay, so eccentric loading originally, they used it for patients with patellar tendinopathy and for Achilles tendinopathy. So, what's the goal of eccentric loading? So we want to induce hypertrophy, decreased pain perception, and it's going to help. We know with a true lateral epicondylosis that we have all these immature blood vessels and nerves and that frame of that tissue, and it's all disorganized. And so we want to introduce load to help realign the tissue, and we want to then grade that as we go up. So we want to do our eccentric loading or any type of strengthening. I'm going to share more on the eccentric piece. And then we want to follow up with rhythmic stretching so that we're helping those collagen fibers realign. And the traditional program, which was published by Alfredson, was doing this twice a day, 7 days a week for 12 weeks. So 3 sets of 15 repetitions. Now, in their studies, they had inducing minimal pain. I have found with my patients, if it induces pain, they don't do it. I've done it pain free, and I've had really good results with it. So I think It's you just want to make sure they're going to do it because it is a commitment,
Well,
So,
and part of that is too, is if we think of it from a strength and conditioning perspective, the idea that if you want tissue hypertrophy, if you want tissue modeling, you have to get to a certain load to be able to do that. With that said, though, there's a couple caveats to that. One would be if it's really painful. First of all, compliance goes down, like you said. But secondly, if it's really painful, are we not changing what is firing, shutting things off that might
I think we're
otherwise
continuing with
wanna.
that CGRP in some sense too,
Yeah,
aren't we? I agree.
absolutely, yeah, so we gotta think about that, but then thirdly, we wouldn't if someone came in, I always use this example, and they wanted bigger biceps, we wouldn't have them lift biceps twice a day, 7 days a week, and hope that their tissue got better.
Right. Right. Absolutely. So when I think about too, and I haven't touched on yes, when we're looking at the elbow itself, we've got to look at the whole kinetic chain. And there's a lot too in the literature that we need to make sure we have good core stability, good scapular stability. But when we're focused on if we're doing an eccentric loading program for the elbow, um, pain-free, at least in my opinion,
Mhm.
pain-free, and, we want them to be diligent with doing it at least once a day. If
Right.
they do it twice, that's great. I'm just happy if they can do it once. What I have found clinically is their pain reduces, like, at week 3 or 4, it goes down a lot, but I tell them, "You gotta keep doing it for 12 weeks," because we want that tendon to be able to sustain the load of daily life, not just to get pain relief. So,
Right.
there was a really nice systematic review that Zakeen Chen, who is a hand therapist in Singapore, published. It was a meta-analysis, and she looked at all the different types of strengthening because you see over the years, and that's one thing I've really enjoyed with teaching continuing ed courses is how the literature changes. And I think how we treat lateral elbow pain from an exercise standpoint has changed. One of the things that's changed the most, I think, with understanding with eccentric loading because there was some talk like, well, it's not a weight bearing structure like you have for the knee or for the ankle. But and again, this may change in the future, but what we've got right now is that looking at all the different types of strengthening for lateral elbow pain, that eccentric strengthening is superior to other treatments in reducing pain, improving function in the short term, demonstrating large effect sizes. So that's what we know today. Now, if we do this podcast in 2 years, that
We
will
might notice a
likely
good
change
difference.
because things are always changing. But I think it's important that we need the loading is important and the
Yeah, I think that's the
consistency is
key thing that I really want people to hear is because again, as we look at even the Achilles literature and the patellar tendinopathy literature, it is somewhat going to saying maybe concentric, eccentric, doesn't matter. The key thing is get the load. But we go back to the foundational principle that you're saying, which is load, right? And that's the key thing, recognizing that there is central sensitization, there's tissue degeneration,
Mhm.
and we are trying to hypertrophy that tissue and calm down the central sensitization. Fair summary
Absolutely.
of
Yeah.
lateral of tendon related
Or
lateral.
tendon related. Correct. Yes.
Absolutely.
I
All
would
right.
agree.
So if we kinda say that, we'll leave that. I do want to get to actually, let's get to, how do we then determine if maybe both, wrist extension, whether it's radial or ulnar, both are painful. I imagine that's a different pathway.
Yeah. So now we'll go back to our exam. They say, ow. I ask where. They say lateral epicondyle with the resisted wrist extension with radial deviation. I follow it up and it's just as painful with wrist extension with ulnar. So now I am no longer thinking maybe just a tendon, but now I'm thinking more joint related because that resistance is now loading the humeral radial joint. So there's a really nice test. Well, there's several tests that have recently been published. Back in 2017, Aragoni and Associates they took a look at because he's a big one when we talk about articular. He talks about articular reasons for lateral elbow pain, which again we see more and more in the literature supports. So what he published, and it was a small study, it was only 10 people, but what he found was these patients with lateral elbow pain can have microinstability or an interarticular pathology. So for clinicians, he came up and the guy loves acronyms. So he called the SALT test and the pepper test. Now, I have to always think, what does SALT mean? So the SALT test it's called supination with anterior lateral pain test. And what happens basically is you're going to have the patient's going to have his elbow flexed to 60 to 70 degrees, and you're going to place your finger over the radial head. And then as they supinate, you're going to be pushing your hand over that radial head. So you're going to go in an anterior medial direction. And if that produces pain, he found that indicates the presence of at least one intra-articular finding. So that could be chondropathy, that could be, ligamentous laxity. So that was the first one, the SALT test. The pepper test, again, I got to okay, what is this? The pepper test, posterior elbow pain by palpation with extension of the radiocapitellar joint. Again, pepper is easier, but it's still a little bit of a reach. But basically, what you're doing with this test is you're going to place your thumb between the radial head and the capitulum, and then you're going to have the patient extend their elbow. And what you're looking for is provocation of pain at that posterior aspect of that humeral radial joint. And if they have pain, that indicates radial head chondropathy. So those are the two published tests. There is another test called the Pole or the Wolf test, which is one that's from James Syriac's that he discusses and that we use a lot in the clinic. And the Pole test, basically what you're going to do is if you find pain with both resisted wrist extension with radial deviation and ulnar, is you're going to come in and you can do this with the elbow flexed if they're more irritable or with the elbow extended. But basically, you're just going to do resisted wrist extension. Okay. And you'll have your hand just on their distal aspect of their radius. And if you're doing it in flexion, you're going to have their ulna stabilized just to have like a cuff weight to have their elbow resting. Then you're going to do part 2 of the test where you're going to pull along that radius. So you're going to basically take that radial head and you're going to try to pull it away from the capitulum, and you're going to repeat that test. And when you do that, you want to see, is there pain less and or strength more? If it is, that tells us we're dealing more with a chondropathy. If their pain is worse when you pull on the radius, that would indicate more of a tendinopathy. So you can do that both with flexion and an extended position. If you do it in flexion, like with their elbow on the table and it's positive, then you're done. You don't have to do it in extension. But that test can be so valuable because now, I know I need to improve that portion of the elbow capsule, that mobility, so that radial head's not constantly pushing on the capitulum. And it's been fascinating to see. I had a patient, one of my roles in the clinic where I work is I help mentor new therapists, which I love. I love to teach. So this therapist came out to me and said, Anne, I have this patient.
A
He
hypothetical patient, of course.
Hypothetical patient.
Of
Yeah.
course. Okay.
Yeah. Okay. Came in 8 out of 10 pain and pain with resisted wrist extension and with grip. Had already been to therapy before. And he's like, what am I going to do with this patient? So we go back to let's do our tests. Let's put the elbow in extension, do resisted wrist extension with radial and with ulnar deviation. So with radial deviation, he had 8 out of 10 pain. And with ulnar deviation, he had 8 out of 10 pain. So now we're steering less to the tendon. Not that we're not going to address the tendon eventually, we will, but first we've got to address the joint. So then following up with performing the pepper test was positive, as well as the pull test. So for treatment, what would we do for this patient?
Hang
Well,
on there 1 second. Let's pause because I just wanna kinda put a bookmark here. We're gonna have all these special tests. Can we have videos of these to
yes,
put into the links to the handouts, or in the handout in the resources? Because I
yes,
think these tests, I just wanna kinda break this up here for a second because that diagnostic strategy right there is probably the most important part. We're gonna do treatment here, and we're gonna get to treatment because I think
yeah,
it's got
and
a
I
lot of
agree.
important
Yeah,
but I don't wanna gloss over that diagnostic strategy because I just wonder, could it be that the reason that eccentrics have, let's say they have a, 60 to 80% efficacy rate. If you just throw eccentrics at everybody and
yeah,
and
what
and
happened?
hope for the best, you probably get a decent but not great resolution of symptoms. but that other 20 to 40% then go see you because they
I
need
don't
a
get
little
better.
bit more a little bit more specific diagnostics there. So if we can make our diagnostics better, we like it could be potential that what eccentrics or concentrics or strengthening is doing is kind of giving some strength, some stability to a hypermobile joint. So it might just be helping for that. It might be the right thing for the wrong reason,
Mhm.
and so it kind of clusters everything up. I kind of think of that. Let me give an analogy in the lower extremity. We know that hamstring strains can be prevented by Nordics, so eccentric hamstring strengthening decreases hamstring strain rate by 50%. And one of the hypotheses of that is that we're increasing the tissue tolerance of the hamstring, right? We're increasing its load so that it can tolerate more load so that it doesn't get strained as easily. But with that said, the other thing that we're doing at the same time is actually working on core stabilization while we're dynamically eccentrically lengthening that tissue that gets strained. And so it is it just that we're improving the capacity of the tissue? No, I think we got a lot of other things going on. So maybe am I off base there? Maybe that's why eccentrics have a good place.
I agree. I agree. Yeah. Um, I think we tend to miss, and the reason why I think a lot of clinicians get frustrated with treating lateral elbow pain is I think we miss as a therapy group, we miss the joint related issues. So it's really nice to see that we're starting to see more of this in the literature, which is helpful for us because we know these patients, if we treat the tendon, they don't necessarily always get better.
Right.
Like we need to
Right.
have something else with that.
And
Uh,
why not do it earlier rather than later? Okay, so we've gotten people so everybody after listening to this should now be adding at least 3 tests or well, we should be already doing the other, but 3, 4 tests as a good test battery to really do a differential on our lateral elbow pain in adults, right?
yeah.
Because we got to remember where
Right.
we're at, right? With lateral elbow pain in adults, we've got a new test battery, a little bit more diagnostics that we can go around. I interrupted you before we got to some treatment for this instability. Can we go down that road now?
Well, can I back up for one more thing I want to
Sure.
add when we talk about the alignment is don't forget about the medial side of the elbow
Okay.
because if you have laxity in that anterior band of the medial collateral ligament or ulnar collateral, whichever you say, but
Right.
if that is lax, you're going to get more valgus of the elbow. So you're going to get more loading
Uh,
of the radial head on the capitulum. So for those patients, don't forget to do a valgus stress test or moving valgus stress test because if you find laxity there, your treatment first is gonna be to offload. You don't want that radial head constantly pushing into the capitulum. So now you're gonna look at all of your muscles that you're gonna dynamically stabilize to help with that medial sided ligament issue.
so in that case, the symptomatic structure is the radial head, the causative structure is the medial elbow. So the root
Correct.
cause versus what's barking at you. We see that all the time throughout the
Yep.
body.
Exactly. Exactly. So I don't want you to forget about that as well. So now let's go back to treatment. So we have a patient that has pain with resisted wrist extension with radial and ulnar deviation. We perform that pull test, and when we pull, the pain is less. So maybe it's from 8 out of 10, now it's at a 4 when he gives resisted wrist extension. So what are we going to do for treatment? Well, the first thing we want to do is we want to stretch out that portion of the joint capsule so we don't have that constant loading. So in the clinic, I'm going to do some tractioning to that humeral radial joint. I want to pull just on the radius to want to give that more space. And then I'm going to have him do that at home as well. I'm going to have him grasp just his distal radius, not his whole forearm. And I'm going to have him pulling intermittently during the day to unload it. Then I want to start addressing, I want to have him starting to do some rhythmic stretching as long as it's not painful. And once we have normalized that capsular mobility so it's not constantly pinching, then I'm going to have him start on the eccentric loading. So treating the joint, and this is one of the concepts from Dr. James Syriac's. If there's a problem with the joint, you treat the joint first. And here is a big case where you're going to spin your wheels otherwise if you just treat the tendon because it's just going to irritate the joint.
But I think the key message that you said there though was this is not a one thing or another. This is you actually have to treat, you have to be strategic in your diagnosis and treat all the things you find treating the joint mobility problems first, as at least before or simultaneously as you go after the tendon issues, because most likely the person who's coming into you with this, it's been going on a long time. So what might have started as a micro instability or a gross instability has now gone into a tendinopathy, right? Because it's just the chronicity of it.
Right.
But if you just treat the tendinopathy, what I hear you saying is then you've missed the instability, you've missed the root cause of that, and you're just kind of almost putting, a band-aid on the solution, so they don't see the long-term results and the really high quality results then.
And that's why too, when they start to do heavier activities, they start to get more symptoms again, and I think that adds to clinicians' frustration. So understanding the underlying joint related and how to test for that, I think can make these patients fun. I mean, I really enjoy when I find a good pull test and pepper test, and I can work on getting that alignment back and then starting the loading, and it's magical for these people. They're so happy.
To me, and I don't want to get on too much of a professional soapbox here, but this is the difference between the ability to go and watch something on YouTube, and like eccentrics are not that hard to do. You can watch a video. If you have lateral elbow pain, let's just go do eccentrics. That can be done by just about anybody, but it takes a professional like an athletic trainer or a physical therapist to go through, the occupational therapist, the certified hand therapist, all these professions, to go through a systematic evaluation and problem solve and pinpoint, hey, maybe there are four things going on and we need to address these and we need to address them in this order. Or maybe there's just one or two. And rather than addressing all four, we're going to address two. So we're not wasting time or doing things
Or
that don't need.
visits with
Yeah.
patients with limited visits, and I had a patient yesterday at $100 copay per visit. Like,
Wow.
okay, I've gotta
Yeah, there
be
we go. Let's
on
be
my
efficient.
game.
Yeah. Oh,
Yes. Yep.
that's so incredible. So, we've hit, tendon issues, we've hit instability issues. Let's go back and take another step back, because you said something that I believe was really important earlier that I wanna address. So we just to kind of recap for everybody, we've identified whether it's tendon, we've identified whether it's joint, we've identified if it's both. We know we're gonna do eccentrics. We're going to do work on central sensitization with our tendon issues, joint issues. We're going to work on appropriate mobility and stability depending on where that's coming from, and potentially eccentrics as well. But you said, hey, wait a second. Let's make sure the entire chain is where it needs to be. The shoulder, the neck, the mid back, the core, all of that needs to be in place. I still remember in my Doctor of Science training, one of my favorite statements was, "Hey, if you're seeing with someone with an elbow problem, you missed the neck and shoulder about 6 months ago." Um, so
Is that the truth? Oh my goodness, that's
right, so
really
so
yeah.
with that, so help me walk me through the process that core stability is important in here.
So, and the other one I wanna touch on too is radial nerve, which we haven't
Okay,
discussed
yeah, let's hit
yet
that. Let's hit
too.
that before we go.
So talking about the whole kinetic chain, I like to use Dr. Kibler's screen that he uses like with his elbow patients. He'll have them just on a single leg support and then try to do a squat. And if they can't hold themselves, like they need to work on core stability. So that's the little screen that I like to use in the hand clinic. And then I like to do manual muscle testing, looking at their cuff, internal, external rotation, and then looking at their scapular stabilizers, primarily lower trap, middle trap, and serratus, because a lot of them have a lot of weakness. And finding those issues and addressing those takes the load off of the more distal structures. And
Well, you think about that single leg squat test by Dr. Kibler, right? And obviously he's very upper extremity athlete focused and things like that. We think about how reproducible are your pitching mechanics if you're on single leg
right,
stance,
they're unstable.
you're all over the place. How much does that increase the stress on the elbow? How much does that increase the stress on the shoulder? But with that said, it reminds me, we had a selective functional movement assessment course recently here, and there were a ton of OTs and CHTs and alongside a physical therapist, and it was kind of like very eye opening to see what you said there is like, hey, if we're not looking in a systematic way to know the person has good core stability and what is their rotation at their thoracic spine, and have we isolated it there? What is their strength in their shoulder, and have we isolated it there? What, mid trap, all those kinds of things are so important. So I love that concept, and it also goes back to the concept of that I kind of led off the episode here with a little bit is how much of this is coming from the neck?
Mm,
Meaning, how often do you see someone who maybe had neck pain and then then develops it, but they don't put two and two together.
right.
It's we
Right.
get a little bit of nerve compression at the cervical spine, not maybe even crazy pathologic, but just enough decreases, that impulse to the muscle. We now have an underuse phenomena, tissue
Mhm.
degeneration. Talk to me about that a little bit.
Well, excuse me. Well, and I think about the cervical spine and also thoracic outlet that can also
Yes.
play a role. So when we think about cervical spine, it's super important that you have to screen for that because a lot of people have issues and maybe not enough that you're getting a positive Sperling's test,
Mhm.
but they do have mechanical issues. And what I see a lot in my practice is that the upper cervical, so C01 and C1 and C2 are very stiff. So the lower cervical, that segment gets a lot of tractioning on the nerve,
Yeah.
which again has adverse effects downstream. If we go a little distal to the thoracic outlet, which maybe we need to have a discussion
But that
sometime
probably is a whole nother episode, right?
other episode. We see actually with thoracic outlet more commonly ulnar nerve involvement, but you've got those three gates that the brachial plexus goes. It goes between the scalene triangle, over the first rib, under the clavicle, and then underneath pec minor. And we think about with our mechanics with how we move. And this is I see more and more of this, unfortunately, because we're all hunched over working on our little devices, even at a younger age now. And so what we end up with is tractioning on the nerve, either at the costoclavicular space because the first rib is elevated, the scalenes have pulled that up, and then the scapula is more depressed, and now we have that excessive tension, which again can contribute to central sensitization. So not only working on core stability, but working on getting the scapula in a better position, addressing first rib issues, that can have a profound effect on their neural function, the blood flow to the nerves. And it's not enough because the tractioning is intermittent. So it's not enough to cause axonal damage, but it's enough to cause symptoms. And that intermittent traction happens like the whole time during the day when they're reaching or doing their daily activities, whether it's reaching or whether it's lifting tasks. So it's really important that you need to look upstream. And it's been neat to see, I think more and more hand therapists are becoming aware of that and
Yes.
are integrating that, which I think is so helpful.
That's
So
so incredible. Absolutely. And again, you're preaching to the choir on that one here that, hey, maybe the whole body is integrated
right.
in everything we do. So I love that. So we're kind of talking about nerves and nerve entrapments upstream. You talked about radial nerve, and maybe we need to be thinking about that in our lateral elbow pain.
So with our patients that have radial nerve symptoms in combination with true lateral epicondylgia, it's a small percentage, only 5%. Sometimes though, unfortunately, we see it self-induced if they get like a tennis elbow strap or a counterforce brace and they're cinching that up and that's irritating the radial nerve. But the location is going to be different when you have a radial tunnel issue versus at the lateral epicondyle itself. It's about 4 to 5 centimeters distal, so more in the central aspect of the forearm. Patients will complain of fatigue and they'll have pain, like with gripping, but when you ask where, it's going to be at the dorsal forearm and not at the lateral epicondyle. So, some tests that we can use trying to figure this out. One is called the scratch collapse test, and that's something that Dr. Elizabeth Haggard has really helped to bring awareness to. And what that test looks at, it's a test that you're not scratching, but you're brushing across the potential nerve entrapment. So you're starting with first testing resisted shoulder external rotation, and you're testing side to side comparing. Then you're going to brush across that area, so that radial tunnel, and then you're going to repeat that test. So this is if they have a peripheral nerve irritation, that's going to cause an ipsilateral weakening. It's a reflex arc. So they will have immediate weakness with that as soon as you test it. You have to test it right away, because if you wait 20 seconds, that reflex arc is gone. But that is one test that you can use for radial tunnel. There are others out there as far as their their resisted finger extension. That can bother it, as well as you'll sometimes see it with their upper limb neurodynamic test number 2 for radial nerve.
Oh,
That one I
yes.
don't rely as much on, because what we see in the literature is like we can't always bank on, if that's negative, that there's no neural involvement.
Or if it's positive that it is neural involvement, right? I mean,
Right. So
it does.
you like to look at the cluster of
It
tests.
is. It's multiple things. Just like we talked about with the lateral elbow, looking at
Mhm.
tendon versus joint and things like that. Unfortunately, they don't exist in isolation very frequently.
Right.
And if we miss one, we're probably missing. We're going to really not have the optimal treatment there. Wow, this has been a jam packed episode here. I really want to make sure that we do get those videos of all those
Yes.
special
Mhm.
tests, get
Absolutely.
links to those into our handout, because that's just going to
Mhm.
be a great resource for people. And we can even look at doing a little bit maybe of that algorithmic thinking there. I think a flow chart would be amazing in that
Mhm.
in our show notes there. So that looking forward to that. Okay, let's get to what are our 3 key takeaways that we don't you this is the stage. This is your opportunity to affect all hand therapists, occupational therapists, physical therapists, athletic trainers, and some
Uh-huh.
people just sitting here listening who have elbow pain.
Okay.
This is your show right now. Tell us the 3 main takeaways.
So I think the first thing is you need to be specific with your exam and to determine the pain generator. And part of that too, you don't want to palpate the structure first. And the one thing that I really struggle, you want to palpate last after all your tests are done. Because if you push at that lateral epicondyle, they're like, oh yeah, that's the spot it hurts. And you do all your tests, everything is going to reproduce pain. So
Sure.
be specific with your exam, save your palpation for last. So when you know what that specific pain generator is. So if they have a joint issue, you want to treat that first, and then you add the loading. Because if you load with improper alignment, it's just going to potentially make things worse. So that's the first one. You want to be systematic. Okay. So in and just the 4 tests that we talked about, even don't stop. I've stopped doing altogether resisted wrist extension because it doesn't tell me anything. I go right into my quadrants right away to add radial and ulnar deviation, because that gives me more information. So second thing for tendinopathy, so consider soft tissue techniques. So dry needling, transverse friction, instrument assisted soft tissue, and the eccentric loading. Remember, any type of loading is helpful, but we want to make sure the joint's in good alignment before we initiate that. And 2, really sitting down with the patient, explaining the importance of diligence with being compliant or adherent with performing that. Because I think a lot of people, I tried it for 2 days, it didn't work. No, you need to try it for a longer period of time, and you need to be diligent with doing it on at least 1 time a day. Some of my patients do it twice, which I'm really happy, but at least
Right.
once a day.
That's awesome.
And I think explaining to patients too, like, this is your collagen that makes up your tendon is all disorganized, it's unhappy, and that we need, if you want to go back to whatever activity that is, whether it's work related or recreational, that you need to build that collagen on that tendon so that it's going to be able to be sustainable. So it's going to be able to tolerate that load without pain. So, and then the third thing with articular issues, that don't forget about that radial head. You can have hypermobility or hypomobility. And the one we didn't talk a whole lot about is people can have microinstability with that posterior lateral rotatory instability where that lateral ulnar collateral ligament is involved. And what we see in the literature is those patients that have that microinstability, they've found a correlation with they have a higher visual analog with pain, higher scale with that. And they also have had a history of multiple corticosteroid injections. So
Mm.
very important. If you're seeing their history, like they're at 8 out of 10 pain all the time, and they've had 3 injections, maybe from, I don't know, several different providers, now start thinking about they may have an underlying lateral ulnar collateral ligament issue. And that
Now, just dive in. Is that a referral at that point for
referral, I would just say,
surgery?
yeah, that's a referral because that's not something that we're going to necessarily change. Now, you can try it, but
Right. So let's
yeah,
let's give 4 weeks of
yeah, and
doing
see what
exactly
happens.
what we talked about in this
Yes.
episode. Let's give that 4 weeks. If we're seeing 0 improvement, I'm going to be much quicker to refer and say, "Hey, someone that understands this who can do this surgically a little bit better needs to take a look at that," which probably means getting to the right person too.
Because we think of PLRI more with a traumatic event, but now we're seeing that can happen just with our just degenerative changes. So it's important to just keep that on your radar if you hear that in your patient's history. So
Absolutely. Wow, this has been such a great episode. I mean, my goodness, like I don't know that we could have gone through more more information. This is one that I will go back and listen to for sure. So, to kind of wrap us up, drive us home here, if you could go back and speak with yourself as a new professional, we love to ask this question. What advice would you give?
That's a great question. I think the biggest thing is to be systematic with your evaluation and don't discount the patient's history. I didn't understand how important the history was in my first few years of practice. Now, that is like the critical piece. What's their age? What's their sex? What's their occupation? All of those things start to help me figure out what are my possibilities so that when I do my physical exam, that can help confirm it. And I think a lot of newer clinicians, and like I said, myself included, I'm like, okay, oh, I got this, whatever. When I have therapists come to me and say, I have this patient, my first question is male or female? How old are they?
Right.
I want to know those things. So now I can think about that. So, and this is something we didn't talk about today, but we think about like, if I didn't take into account that patient's history. Like if I have a 10-year-old little league player with lateral elbow pain, I know it's not going to be a tendinopathy. It's going to be a Panner's disease or something, along those lines because of the valgus from throwing and not going to be a tendinopathy. So having that knowledge of that history gives us more understanding of where we need to go with our exam. And that's going to help us be more efficient with treatment. So
Absolutely. Oh, that's so awesome. How can people connect with you?
Oh, well, so I did just start an Instagram account because a therapist was sitting in the audience. She's in her 20 something. She's like, Ann, you need to get on Instagram. Go stand along the wall. I'm going to take your picture. I'm going to set up your account for you. So
Nice.
I'm learning. I've been on there a
That
year.
person probably needs to contact me so they can, help me too.
But I'm on Instagram. I'm on LinkedIn as well, and I really enjoy like the clinical problem solving. That's really my forte. It's fun, especially the more challenging patients. So I really appreciate the opportunity to be on and to talk about all of these things that hopefully will make lateral elbow pain more fun to treat.
Oh, absolutely, and this has been an absolute blast for me, so I've enjoyed it and learned a lot too, so it's, absolutely incredible. Thank you so much for being on. If you'd like to connect with me or find out more information or what I'm up to, what I'm learning, I'm constantly learning, you can find me at philplisky.com, and, until next time, let's keep building the future of rehabilitation and performance together.
Thank you for tuning into this episode of Rehab and Performance Lab by Medbridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the Medbridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your Medbridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you'd like to see addressed on this podcast, please let us know by leaving a comment on our Instagram post or by emailing podcasts@medbridge.com. See you next time.